Before we begin tonight's program, I'd like to introduce Mara Berger, who's also a member of the Young Leaders Committee.
My husband Brendan and I started off February 2020 with the shock of a lifetime when we found out we were having twins. 2 weeks later, the world shut down, and here we are, still navigating the ever-evolving waters of this pandemic while trying to keep our 7-month-old twins as well as our 3- and 6-year-old big kids healthy and safe. It has never in our lifetime felt more essential to be a part of supporting our frontline healthcare workers and the incredible hospitals where they practice, which is why we felt so strongly about joining the St. Barnabas Young Leaders Committee. We look forward to sending our big kids to camp this summer and are grateful to learn the most up-to-date health and safety recommendations this evening. It is now my pleasure to introduce Lauren Farrand, Clinical Director, Pediatric ICU, and Nurse Navigator, Pediatric Post-COVID Care Program, who will be the moderator during our important discussion.
Thanks, Mara. Thanks to all who's joining us tonight. As a mother of 3 and the nurse navigator for our pediatric post-COVID program, I've seen firsthand the impact of COVID on our children, and I can say that I'm certainly happy to re-enroll my kids back into the activities they love. If you have any questions after tonight's presentation about COVID and safety with your child, our pediatric post-COVID program is still here to support you. Please email us at postcovidcare@rwjbh.org. The information you'll hear tonight is based on what we currently know about COVID-19 and how it spreads. As we've learned over the past year, there are no absolutes. We are continuously learning about COVID-19 as the data is dynamic and it continues to change at a rapid pace. We advise you to consult still with your personal physician about your specific situation. With that being said, we've compiled a panel of experts to help you and your family learn to live safely in our new normal. Joining me tonight on our distinguished panel is Dr. Uzma Hasan, Division Chief of Pediatric Infectious Diseases and Assistant Professor at RWJ Rutgers Medical School, along with Dr. Jay Lovenheim, Pediatrician and owner of Lovenheim Pediatrics in West Orange. I'd like to first welcome Dr. Hasan to join us.
Thanks, Lauren, for the kind introduction, and good evening, everyone. Thank you for this opportunity to discuss this very important topic. So my goal tonight is to give you a quick overview of what we know about coronavirus currently, describe how this virus is transmitted, the spectrum of illness that we see in children, and just go over sort of practical guidance for camps, whether it be day camps or overnight camps. And towards the end, I'm going to talk a little bit about impact of vaccination and what we anticipate upcoming for children for the next school year. So a quick timeline review of coronavirus. We all know latter half of 2019, there was a cluster of pneumonia cases in Wuhan, China, which caught attention. And that's when this novel coronavirus SARS-CoV-2 was identified. Soon after, in January of 2020, the WHO declared this a disease of national concern. And following soon after, in March 2020, we saw the rise of the pandemic. The first pediatric COVID case in the US was actually diagnosed on March 2nd, 2020. Soon after, in the UK, in a tertiary care center, following about a month after their peak in the pandemic, which was April 2020, in May 2020, they noticed a cluster of children presenting with unusual symptoms, with fevers, rashes, getting very sick, had multiple organ system involvement, and there was the rise of the multisystem inflammatory syndrome. Following that, pretty much all parts of the world started reporting the same. The current statistics for COVID in the US, almost 31 million plus cases and almost 570,000 deaths. Over the last week, there has been a decline in hospitalized patients overall. And the good news is there's about 230 million vaccine doses that have been administered throughout the US. And now children so far, there's been about 3.7 million cases of COVID diagnosed in children. And this represents 13% of the total number. The good news is, for the most part, children have mild or asymptomatic illness or so. And current New Jersey statistics show that the rate of COVID infections in New Jersey the prevalence is about 261 per 100,000, which represents a decline by 8%. Interestingly, in pediatrics, in the last 2 weeks, there has actually been about a 5% increase nationally in the number of COVID cases. Now, I'm going to talk a little bit about the virus. We all know that this is a coronavirus, which is an RNA virus. It's an enveloped positive stranded RNA virus. And the virus uses a special receptor called the ACE2 receptor to enter into the cells. This ACE2 receptor is found in multiple areas, multiple organs or so. We think that the children are protected from severe disease because they do not express ACE2 receptors to the same extent as adults do. The other thing that protects them is that they see coronavirus strains, which are very similar in structure. So they have protective antibody responses to these strains, which provides them with additional level of protection. Now, all viruses undergo mutations over a period of time. And sometimes these mutations can make them stronger, and sometimes they can make them weaker. All of us have heard a lot about the variants, and there are many, many variants of SARS-CoV-2 that are circulating. The predominant variant, which you may have heard about, is the B.1.1.7 or the UK variant. Other variants that are circulating in the community are the South African variant, the Brazilian strain, and there's some California strains. So what's so special about these variants? Many of these variants show increased transmissibility, and some of them show a phenomena of what's called immune escape, which initially worried some of us to thinking whether antibody responses generated by vaccine would be protective. But the good news is that for the predominant circulating strain, which is the UK variant, the neutralizing antibodies generated by vaccine are still protective. And there are recent studies that there may be cross-protective immunity generated by vaccination. So that is very good news. How is this virus transmitted? So for the most part, it is droplet spread. And the droplet spread is most efficient at less than 6 meter or 2 feet, 6 feet, less than a 6 feet distance. And the virus can also be spread through touching surfaces and then touching your nose and eyes or mouth at that time, but this is less efficient spread. This is called fomite-related transfer. And then another way of spreading is airborne spread, again, less efficient than droplet spread. Transmission of virus is greatest 2 days prior to the onset of clinical symptoms. It peaks about a day after somebody starts with clinical symptoms, and it starts to go down by day 7 of illness or so. And in many studies that were done, the ability to transmit virus after 7 days was thought to be very, very limited. Now, the other thing we know is that some people may have test positive for several weeks out from the time of diagnosis or so. And we have learned from recent studies that this may not reflect contagiousness. We have seen there are certain super spreader events where in particular, things like choirs held indoors, we saw a very high rate of spread, almost about 70 to 80% of those attending the choir and mass were infected. Asymptomatic or pre-symptomatic individuals can spread the virus, but they are much less efficient at spreading the virus, which means that if I'm symptomatic, my ability to spread the virus is about 4-fold higher than if I am asymptomatic. The virus is readily inactivated by the EPA-approved cleaning agents, and we can get a list of these agents at the CDC website. One example is if you use a 60 to 70% ethanol solution, it takes literally 1 minute to inactivate the virus from your hands. So this is something that we keep reminding children who are either in the school setting or in daycare or in camps. Couple other things that we know from transmission data in household clusters, where they looked at about 30 household clusters, the The primary spread was related to an adult spreading or an adult who was symptomatic and spreading. And children were identified as the index case in less than 10% of these cohorts. Similar data has been seen in school settings and in daycare settings where the spread tends to be more from an adult to a child or an adult to an adult rather than the other way around. That being said, you know, all the preventive measures that have been reinforced should be practiced. Now, there are certain activities that are associated with a higher risk of spread. There are certain wind instruments, singing in choirs, indoor sports, etc., are a much higher risk, or contact-related sports, much higher risk of spread. The spectrum of illness in children is varied, and like I mentioned, for the most part, they're mild or asymptomatic. There are some children who will present with pneumonias, just like the adults do, and then there is the other spectrum of illness, which is the multisystem inflammatory syndrome, which is basically prolonged febrile illness. These are kids who come in with multi-organ system involvement. The vast majority of these children are hospitalized in the ICU setting. The numbers of children who develop multisystem inflammatory syndrome are far few in between. So to put this into context, the rate of positive SARS-CoV-2 testing in children between 0 to 21 years is about 322 per 100,000. And if you look at the number of MIS-C cases, that's about 1 to 2 per 100,000. So less than 1% of the kids who get infected will develop multisystem inflammatory syndrome. That being said, we want to have this on our radar. And what we have seen in our population is that the African American and Hispanic kids are disproportionately affected. So is reinfection possible if somebody has already had an infection? It is highly, highly unlikely. However, in individuals who test positive about 90 days from their initial illness, we do consider reinfection. And is infection possible in vaccinated individuals? Again, less likely. And usually if they were to get infected, their duration of viral shedding is much smaller. And the chances of developing overwhelming illness tends to be less. Now, the different types of testing are available, and there's antigen-based methods, PCR-based methods, and antibody testing. So how do I know how to get my child tested with what? We recommend PCR testing as the gold standard. Now, antigen-based testing can be used if the suspicion for illness is high. So if I have a contact with somebody who's known COVID positive and I have mild onset of symptoms within a couple of days or so and my antigen test is positive, that tells me that I truly do have COVID. Antibody testing is typically done about 2 to 3 weeks out post exposure. Typically, we have been doing this in children who have multisystem inflammatory syndrome, as this is part of their diagnostic evaluation. Now, moving over, changing gears to camps, and what does the CDC tell us about guidance for camps? There's different types of camps, as you are aware, and the couple things that we know, which my colleague Dr. Lovenheim will touch on, is that camps do play a very important role in the development, the social, emotional well-being of children, as well as data suggests that they actually prevent summer learning loss. And there's different types of camps. There's day camps and overnight camps, and depending on multiple things, separation anxiety, a beginner, a parent may opt for either a day camp or an overnight camp. The CDC has laid out risk categories for camps depending on how the camp is structured. The lowest risk is if you have small groups of campers who are staying together and they remain 6 feet apart and they're not sharing any of their equipment. Slightly higher risk is these campers who are mixing groups at camp, but they do stay 6 feet apart and they do not share objects. Optimally, you want all children to be belonging to one particular area to be part of the camp to minimize risk of exposure. The higher risk groups are when the campers are allowed to mix together, they do not remain spaced apart or so. And the highest risk is when you have the mixing, plus these are children who are from different localities or so. So the CDC laid out some general guidance, which we already know about for keeping our kids safe when they're going to camp. The couple things before entering camp, now the kids, a lot of these camps have protocols for testing for children anywhere between 1 to 3 days before arrival at camp. If it is an overnight camp, the recommendation is that the child quarantines 14 days prior to arrival at the camp. And what do I mean by that? They don't have to be masking at home around their family or so, but the recommendation is that they do not go into big gatherings just prior to entering camp where the chances of exposure are higher. Many camps will recommend testing in particular for overnight camps, about 3 to 5 days out after they have arrived at camp. Any counselors or adults at the camp, we strongly encourage that they get vaccinated. If a child is sick, they must stay at home. The camp should have protocols for screening, and this includes screening of symptoms, temperature checks. They should have a protocol in place for what would happen if a child tests positive. They should have a protocol for cohorting in place, and general household measures for prevention should be reinforced. So physical distancing, hand hygiene, easy access to alcohol-based rubs or so dispensing devices, which include soap dispensers or alcohol-based gel dispensers, should be sort of touch-free. They should have cleaning and disinfection protocols in place, and they should have a plan for contact tracing in place in case somebody tests positive. Optimally, these children should be in pods or cohorts where they have limited contact with the campers within the same cohort, which helps. The couple other things is that we recommend restricting visitors from camps if somebody has gone home for the weekend or so for those who are in camp for a prolonged period of time, they have to be screened vigilantly when they head back. A couple other things in terms of activities, the CDC actually has laid out very nicely what sports are acceptable. If somebody, if this is a camp where they allow kayaking and other things, how equipment should be cleaned. And then physical distancing, what's acceptable and what's not. If the campers are within a cohort, 3 feet is deemed an acceptable distance. However, if they're interacting outside their cohort or they're interacting with staff members, etc., they should be more about 6 feet apart. Hand hygiene signs should be placed at multiple places in the camp. Gentle reminder to make sure that the kids are washing their hands. High touch surfaces should be disinfected with EPA recommended disinfectants. And then, outdoors activities are strongly encouraged. There is a very high risk of spread in an indoor setting. Which brings me to what about overnight camps and lodging? So optimally, we want all children who are part of one particular cabin to be staying together. The counselors responsible for management of this cohort of children should be the same counselors each time. They should have cleaning protocols in place. If they have bunk beds, typically the recommendation is that they be facing in opposite directions. So, and if they can optimally be spaced out, you want them to be spaced out by about a 6 feet distance. You want these areas to be adequately ventilated. And like I mentioned, again, stringent cleaning protocols and isolation protocols in place in case somebody tests positive. Towards the end, I am just going to go over some guidance about vaccination and what to expect. So as you're all aware, there's 2 mRNA vaccines, the Pfizer and the Moderna. The Pfizer is approved for 16 years and up. Moderna is 18 years and up, and Johnson & Johnson was, again, 18 years and up. Where are we with pediatrics? There are pediatric trials on the way, and what we have seen is some really promising data with Pfizer, where in the age group between 12 to 16, there's almost 100% protective antibody titers generated. And we are pending EUA approval for this vaccination in this age group. When do we anticipate that we have pediatric vaccines available for the younger cohorts? So they are now doing dose de-escalation studies all the way down to 6 months or so. And the earliest that we think will be the latter half of this year or probably early next year that we would have some data on that. I was also asked to comment quickly on transmission in camps. You may be aware of the two major, one major spreading event and which occurred in Georgia earlier in the pandemic, where masking, social distancing measures and ventilation measures were not adequately enforced, where we had almost about a 44% spread from one symptomatic individual within about 260 children and adults testing positive. On the contrary, in a camp in Maine, there was about 4 settings of this camp, about 1,000 children and adults, where they had stringent screening protocols in place. All campers were screened within about a week prior to arrival, and they were screened about 3 to 5 days after arrival. They identified about 12 pre-symptomatic or children. These children were isolated. Subsequently, they had about 4 other cases or so, but they did an excellent job of cohorting and identifying early, screening and reinforcing masking, physical distancing, ventilation protocols, which really limited spread. So what we think is that it is safe for children to get back to camp provided all these preventive measures are exercised. With this, I am going to transition it back to Lauren. Thank you for that.
Thank you, Dr. Hasan. We do have a few questions from participants in tonight's webinar. The first one being, I heard that you touched upon vaccines and the good news that trials are on the way and we're getting closer to a date for our younger kids to be vaccinated. Can you talk a little bit about the side effects that we may see in children versus the side effects in adults from vaccination?
Thanks, Lauren. That's a great question. So I think that gives me an opportunity to launch into dispelling some myths about vaccination. Some of the things that we encounter in the outpatient setting is when we have children coming in who've been hospitalized for COVID, this is our opportunity to advocate for vaccination for the adults in the household. And we've had a lot of hesitancy that we have experienced. The couple things to let everyone know is that the vaccines are not incorporated into the genome. The mRNA, I'm talking about the mRNA vaccines or the adenoviral vector vaccines. With the initial vaccination, you can have some swelling or localized swelling at the vaccination site. With the second dose, some people have reported some headache, some fever and chills or so, which lasts for about 24 hours. But for the most part, the vaccines are very safe and highly efficacious. The allergy data that had come out initially was far few in between. So, for the most part, there were the individuals who had overwhelming anaphylaxis had allergies to particular components of the vaccine or so, and between the millions of doses that have been administered, they have been done so safely. The recommendation is if anybody has severe allergies that they should be observed for a longer period of time, about a 30-minute period. And I anticipate we are going to see pretty much the same in children.
Great, thank you. I think we have time for one more question for you, Dr. Hasan. Will my child be required to have a vaccine to attend camp or school? Can you talk a little bit about the requirements for these kids?
That's a great question. I think, I anticipate that we probably will have vaccine rollout for children probably latter half of this year or early next year. I do not think at this point that vaccination will be mandatory for children to attend camp or to attend schools, just with the transmission dynamics that we have seen. It will, once it is available readily, we will strongly encourage that they get vaccinated. because that does prevent them from severe illness or so, and also reduces the risk of them transmitting infection to the adults. So more to come on that. This is an ever-evolving situation.
Thank you, Dr. Hasan. We appreciate it. I'd now like to welcome Dr. Lovenheim.
Thank you, Lauren, and thank you, Uzma, for a wonderful summary of COVID in the pediatric world. I've been asked to talk a little bit about the importance of camp in children's mental health and physical health. One of the nice things about as far along as we are in the pandemic is we're beginning to have a lot more data on the safety of things like daycare and camps and schools. There have not been significant spreads in most schools and daycares that have followed certain protocols. There are a few camps that were able to have camp over the last summer, and they have kind of led the way in showing us how camps can be safe and what protocols work for camp, whether it's a day camp or overnight camp. One of the advantages of a sleepaway camp, let's say, versus a day camp is that overnight camps can kind of form a bubble. The whole camp can kind of be a bubble by not allowing visitors, by not allowing people to come in and out, by proper testing protocols on the way into camp. And while at camp, they've been able to maintain pretty virus-free environments. In the pediatric world, we started to see kids being severely affected by the pandemic throughout, but especially last fall, we started to see a significant rise in children with mental health issues, anxiety, depression, withdrawing, kids not wanting to leave the house, kids having trouble with social interactions when most of those interactions were done online or through social media. It's become very apparent to us that we need to do the best we can to get kids back to things, to their regular activities and their regular lives as much as possible, of course, in the safest way possible, following proper protocols. One of the things that we know is that the risk of getting COVID is beginning to be outweighed by the effects of keeping children isolated. Attending camp is a huge benefit to most children. They get increased exercise and play, increased social interaction with other kids, and the mental benefits, whether it's confidence, working through their anxiety, and just being around other children, and just being quote unquote normal kids, is a huge benefit to our children. It's something that after a year and some months of this pandemic and being quarantined, that we know that they absolutely need. Summer camp also has a way of helping children ease back into school. Starting in September, it's likely that most schools will be in school 5 days a week, full days. Even today, Governor Murphy in the state of New Jersey said that all camps can open with proper protocols. The protocols that most of the camps plan on following, and the ones that I've seen, seem really robust, safe, and really do a great job of protecting our children and your children from risk of COVID in camp.
Thank you. We do have a few additional questions for you as well. You talked a little bit about the mental health benefits for children. And of course, we've seen the impact that COVID's had on our children's mental health this past year. What do we do for children, and how do we get to help them ease their anxiety about attending camp?
Sure. Going to camp can be a very overwhelming experience for a kid, especially thinking about going to camp. One of the important things is to include your child in the planning process. Make them active participants in getting all their supplies together. Talk about camp at home in a very positive way so they'll look forward to it. We also want to address their fears. Don't run away from their fears. If your child has not had a lot of experience having sleepovers or sleeping away, I suggest if you have grandparents or aunts and uncles or friends, have them do some trial runs and some sleepovers before camp. We want to emphasize and remind them that when they started school, they also didn't know anyone either. And now they probably have plenty of friends. We want to turn camp into something to look forward to instead of something to fear. Saying, I can't wait to hear about all the great people you're going to meet is something that will elicit hope and a positive attitude towards camp for your children.
Thank you. Another question from one of our participants is, if my child's not going to camp, what other activities are safe for them to participate in? Anything with indoor activities or things like swimming?
So many indoor activities have been shown to be safe with proper protocols in place. Currently, the CDC says masks are really probably required for most kids in any sort of indoor activities. And as long as masks and some level of social distancing is put in place, indoor activities are safe. One of the great things about summer is the weather is usually nice and we could take advantage of being outside. And as many of you have seen, the CDC just yesterday released new guidance for masking outside and really decreased a lot of the things that we need to do for masking on the outside. Things like swimming and outdoor sports, things like arts and crafts that can be done inside can be done under tents or at picnic tables. Things like drama and dance and pretend play and dress up are all things that any age kid can do outside, probably oftentimes without masks.
Great. And I heard you mention a little bit about safe protocols that are being implemented for camps and other activities. And I know Dr. Hasan also mentioned some protocols and some recommendations. Do you have anything further you want to add about what parents can look for when they talk about the protocols at their child's camp?
Sure. You know, we've talked a lot about COVID here, but when looking into camps for your children, it's also important to look at some of the other protocols for safety that they have in place. For example, camps should have protocols in place to address kids' food allergies and sensitivities. They should also have plenty of and a robust water safety protocols in place to make sure kids are playing safe in the water, whether it's a pool or fresh water or a lake.
Great. Thank you for that, Dr. Lovenheim. I also wanted to invite back Dr. Hasan for any closing remarks.
Thanks, Lauren. So, you know, I thanks, Jade. That was a very nice overview of things. And, you know, for both of us, we are seeing the mental health impact on children, social isolation, obesity, anxiety, being cut off from their peers or so. We have seen that implementing preventive methods appropriately does truly limit spread and allows a resumption of a semi-normal routine. And we're here to assist with anyone who needs guidance or has any questions or so, but we strongly encourage resumption of normal routines for children, for them to get, you know, be less fearful and for them to be able to experience their childhood as they should.
Great. Dr. Lovenheim, any closing remarks from you this evening?
Sure. You know, a year and many months into this pandemic, we know a lot more about COVID and how COVID affects children than we did a year ago. We know how to control COVID. We know what protocols work. We know what protocols don't work. Between what we know about controlling the spread of COVID and what we know about how COVID affects children, typically not in a major way, it typically does not make them very sick. We combine those two things, and it's time to get our kids back to as many normal activities as possible. It's good for their physical health and their emotional health.
Great, thank you. Just wanted to thank you both for a wealth of information on such an important topic. I think we're all looking forward to getting our kids back into the activities they love this summer and back into their normal routines and what we call a new normal at this point. I'd like to now invite Ryan back on screen with us.
Awesome. Thank you so much, Lauren and Dr. Lovenheim and Dr. Hasan. We appreciate your expertise. And on behalf of the young leaders, we thank everyone for joining. As a committee, we have a goal of raising about $50,000 plus for the medical center. To date, we have raised about half of that goal. As you learn more about St. Barnabas and heard from Lauren, Dr. Lovenheim, and Dr. Hasan, we hope that you'll be moved to make a gift to St. Barnabas and help support the doctors and the staff that provide the compassionate care to our youngest patients. To make a donation or get additional information, please visit sbmcgiving.org or contact Kate Lubinger at 973-322-4305. Thanks so much for your support and your attendance. Have a great evening.